Hello everyone, welcome to our channel. Today we are going to discuss about the Mission 200 Plus as part of our program. Today we are going to discuss about the gynecology rapid revision. So yesterday we completed the obstetrics part 1 and today we are going to wrap up with this revision. And in this also some of the obstetric topics we included molar pregnancy, ectopic, abortion and also MTP. So these are also included along with the other gynecology important topics. So let's start the discussion today. Gynecology, and the first topic will be abortion. So according to the WHO, what is the definition of the abortion? Whichever the pregnancy is lost less than 20 weeks age of gestation, 20 weeks age of gestation with less than 500 grams. Okay, so or either it should be the 20 weeks less than age of gestation, or the baby weight is less than, or the fetus weight is less than 500 grams. This is considered as a classic definition for the abortion, guys. Next, what is the common cause? So the most common cause for the abortions is usually aneuploidies. Okay, if you see the option with the aneuploidy, you have to choose it as a most common. Okay, then if they are not given that, then you can choose the trisomy. Or even if the trisomy also not included, then we can choose the monosomy X. Even monosomy X is also not given, then you can choose the trisomy 16. Okay, this is the how we are going to choose. The most common cause will be aneuploidy only. Okay, that is the first thing that you have to remember. Next, what is the most common recurrent cause? Okay, what is the most common recurrent cause? Then it is cervical insufficiency. Which is the most common cause for the second trimester or recurrent pregnancy loss. Okay, this is the thing that you have to remember. Next, moving on to the what are the types. So the types are as you can see here, these are the types. One is threatened, inevitable, incomplete, complete and missed abortion. So let's see what are these types. Okay, so for example, how can we differentiate these types? For example, if you see the threatened abortion here, the threatened abortion is completely reversible. Okay, it is reversible. And what is happening here? So the abortion is likely to be indirectly due to the internal factors or due to the whatever the chromosomal abnormalities. So what happened here? The os will be closed. Okay, so os is closed means whatever the abortion is going on inside is still we can going to preserve it, because os is closed, so the abortion products is not going to release, right? So whatever the expulsion is not going to come, so that's why this abortion is threatened abortion. So the os is closed, it can be reversed with the expectant management. And what about the bleeding? So the bleeding or spotting will be seen. Okay, bleeding and spotting will be seen, and treatment for this patient is expectant management. And next, inevitable abortion. Inevitable abortion is it's irreversible. It is irreversible. What happens in the inevitable abortion is, here you can see the os is open. The os is open, and yes, the bleeding is also present. So what happening here? Here you can see already some of the products is ready to expel from the patient. So the bleeding and the os is open, high chance they can go into the increased bleeding can cause the anemia or hemorrhagic shock. So what we have to do, emergency, we have to go for the medical or surgical abortion. Okay, we have to opt and immediately remove whatever the products that is present in the patient. Next, incomplete abortion. What does mean by the incomplete abortion? Here also os is open and bleeding is present, but what are the products that is incompletely expelled? So some of the products of conception is still present inside the uterus. So what is the treatment for this? Also emergency suction and evacuation should be done for this patient. Next, complete abortion. In the complete abortion, already complete means all the products of the conception is already came out. So os will be closed here and products of the conception is out. Okay, and no bleeding is seen. So even if the patient is had the history of the bleeding also, when they are presented to our, so already the bleeding will be stopped. What we can do, conservative management we have to do for this patient. Next, missed abortion. In the missed abortion, How can we understand is it the missed abortion or the threatened abortion? Because here also the os will be closed and no bleeding manifestations is seen. By the criteria of ultrasound, you have to understand the findings of missed abortion. What is the findings for this? For example, if you see the CRL, more than 7 mm, or if you see the MSD of more than equal to 25 mm, okay. So if these findings, if you see, and fetal heart rate is absent, then we can consider this as a missed abortion. Okay, we have to consider this as a missed abortion in the early or the first trimester pregnancy, right? This is the treatment protocol that we are going to follow. Next, in this only you have to know about the cervical insufficiency. This is what we discussed, guys. This is the second trimester or most commonly the recurrent pregnancy loss cause. So cervical insufficiency, what is the definition? Usually what happens, the dilatation of the cervix should be happened during the delivery or the active labor period. But if it is happening in the second trimester, the spontaneous dilatation of the cervix is seen, then we have to consider this as a cervical insufficiency. Then how much is the length of the cervix is known as a insufficient. So investigation of the choice is transvaginal ultrasound. On the transvaginal ultrasound, what you are going to see, less than 2.5 centimeters. If you see this length, of the cervix, then we can consider as a cervical insufficiency of this patient. Next, if it is between the 3 to 2.5, then we can go for the active management. The treatment or the drug we can give is the progesterone. So it will maintain the dilatation will be prevented. Or else the surgery we can go for is the cervical cerclage. Okay, cervical cerclage we can opt for this patient. That's the first thing that you have to understand. If it is less than 2.5, then we can go for the surgery. If it is more than 2.5, then we can go for the progesterone. Usually normal how much? It is 4 centimeters, right? This is the pattern that you have to understand. Next, coming to here another picture. What is this one, guys? And here you can see this is the ectopic pregnancy. Okay, so in the ectopic pregnancy, most commonly the ectopic pregnancy where you are going to see in the tubal only. So the ampullary is the most common cause. Okay, ampullary is going to be the most common cause. On the ultrasound, you are going to see the tubal ring sign. You are going to see. And next, there will be the another question. What is the most common non-tubal? Then it is ovarian. The non-tubal will be ovarian. Okay. Next, what is the least common? Then it is cervix. It is going to be very least common site for the cervical ectopic pregnancy. Then we can also have to know about the what are the specific criteria that is given worldwide. For the ovarian, it is Spielberg. For the ovarian, it is Spiegelberg. Okay. For the cervical, it is Plamen. For the cervical, it is Plamen. And for the abdominal, also we have. For the abdominal, the criteria name is Studiform. So it can be asked a direct question also. It is Studiform, right? These are the one of the types. Next, ectopic is going to be presented as a classic presentation. The triad of the ectopic pregnancy will be the patient will be having the amenorrhea. The patient will be having the amenorrhea and lower abdominal pain. Lower abdominal pain you are going to see, along with that bleeding per vagina. Okay, bleeding manifestation. So these three triad will be suspected, and along with that the patient will be also having the signs of orthostatic hypotension. Okay, low BP will be presented and tachycardia will be presented in this patient because of excessive bleeding. This will be also seen. Next, the pain, whichever the radiating pain, so the radiation of the pain will be seen to the shoulder or to the backside of the hip. You are going to see the radiation pain will be also seen in this patients. Next, what happens if they are the patient will be having the high bleeding, then they can go into the shock, which will be causing the severe hemoperitoneum, or even the rupture of the pregnancy can lead to the shock and death also sometimes of this patient. Next, what we have to take note, what is the most common risk factor for the ectopic pregnancy? The most common risk factor for this patient will be pelvic inflammatory disease, okay, or infection. The active infection is going to cause this condition, right? Next, what we can do for this patient, for example, if you see the ectopic pregnancy, you have to take note of the examination, the physical examination important. And on the physical examination, along with the symptoms, you are going to see the classical sign. This sign is known as a cervical motion tenderness. Okay, when you are doing the pervaginal examination, you are going to note down the cervical motion tenderness. Okay, along with that, the uterus will be soft, and the uterus according to the amenorrhea, the size according to the age of gestation will be, the size will be smaller. Okay, that is also you are going to see, right, this one. Next, what is the treatment protocol that you have to do whenever you see this patient? We have the two types. One is ruptured, what is the treatment protocol, and other one is the non-ruptured. Okay, non-ruptured. So let's see. First, if the patient is presented, it is already non-ruptured, then what we can do? First, you have to go for the transvaginal ultrasound. Then you have to confirm where is the location of that ectopic pregnancy, and is it the gestational sac, yolk sac is present or not, is the fetus is having the cardiac output or not. Then you have to do. Next, what is the next step? Beta hcg should be done. Okay, beta hcg value should be done. What is the critical value for the beta hcg? Usually the transvaginal ultrasound we are going to consider it is as a 2000 international units. This is the critical value that you are going to see for this patient. Next, what is the next step that we are going to do? What is this medical management? Usually we are going to give this patient methotrexate. Okay, so the methotrexate drug is given for this patient. This is the first thing. If you see this patient is having this signs. Next, how much critical value? More than 2000 only, then you have to go for the methotrexate therapy. But if you see, if it is less than the 2000, still you have to wait and repeat after the 48 hours. Okay, same action. What is the methotrexate? What is the route that we are going to give, guys? It is given in the IM. And what is the dosage? Usually, how much is the dosage? 1 gram per kg that we are going to give for this patient. Always remember, when you are going to give the methotrexate, always the patient beta HCG value should be more than 2000 to less than 5000 only. And cardiac activity of the baby should be normal. Absent. It should be absent, and patient is vitally stable. Then only we have to proceed further. And if not, we are not going to proceed further treatment. Next, coming to the ruptured ectopic pregnancy. What is the ruptured ectopic pregnancy? What is the treatment that you are going to give? When you see immediately the ruptured ectopic pregnancy, immediately start the patient on IV fluids. Then always it is going to be the surgical intervention only. So in this surgical intervention, if the patient vitals is normal, then you can go for the laparoscopy. Salpingectomy. Then if you don't see the patient vitals is abnormal, if it is you are seeing the unstable, then you have to go for the laparotomy. Okay, this is the first thing that you have to do. And salpingectomy is only the protocol nowadays we are using. In previously there will be the salpingotomy, but now it is only salpingectomy as a protocol for the patients of the ruptured ectopic pregnancy. Next, moving on to the MTP, guys. So MTP, you have to understand, the most important for the MTP is for the guidelines as per the India. Okay, this is important. Let's see what is the importance of the MTP according to the new guidelines of the 2022. So for this amendment, what they included, that MTP can be done for the 24 weeks. Okay, but the rules are applied here. In what cases we can go for the 24 weeks? So the 24 weeks is done only for the patients of those who have the social cause, for example rape or such cases, and if the patient is having the anomalies the anomalies or the mental disorders or the systemic disorders to mother, then only we can proceed. For contraceptive failures, it is still 20 weeks only. Okay, for the contraceptive failure, it is still going to be 20 weeks only. Then if they have to go for the 24 weeks, they have to go for the how the qualification, how can we understand which patient should be go to the which patient. For example, if the patient is less than 20 weeks, the only one doctor opinion is fine. Okay, one doctor opinion is fine. If it is 24 weeks, then we have to choose at least two doctors opinion. This is the protocol that you are going to follow. But even if it is more than 24 weeks, then we need the medical board. And in this medical board, what are the who are the persons going to check this one? One is pediatrician. Okay, pediatrician, and then gynecologist, and also sonographist or the radiologist going to check this patient. Right, these board has to confirm and understand that yes, the upper limit more than 24 weeks is needed for the medical termination. This is the first thing. Next, who can perform? RMPs can also perform. Who is RMPs? Like a registered medical practitioner, completed the MBBS study and also cleared the examination, and these RMP should be assisted at least 25 MTPs by his own. Okay, who has already completed the 25 MTPs and 5 MTPs at least he has performed by himself, him or herself. Okay, that they only have to perform this MTPs. Okay, and consent, coming to the consent, no partner consent is needed. Okay, no partner. If 18 years less or the patient is mentally unstable, then we can go for the guardian. Okay, but partner consent is not needed. Right, first thing, only the consent that we needed is from the whoever the female is going under this termination. That is the first thing that you have to understand. No need of the FIR, no need of the marriage certificate, no need of the age proof. Only you need the female consent that should be given, and you have to maintain this records until 5 years. And what is the protocol that you are going to follow for the termination? You have the two types. One is medical. Usually the medical is going to be less than 9 weeks only. Always after that it is going to be the surgical, and in that surgical you are going to be choose for the surgical for all the patient who is more than 9 weeks. Okay, it could be suction or evacuation, or it can be dilatation and curettage. All this will be done for those patients. Next, methods of the MTP we already discussed. Medical abortion. In this medical abortion, what are the drugs that we are going to give, guys? We are going to give the two types of the drugs. Okay, first one is the mifepristone, and next one is the misoprostol. So mifepristone dosage is 200 milligram. One dose is fine. Okay, and next, coming to the misoprostol, it is given as a 800 micrograms. Okay, orally, both are given orally, and these 800 grams can be given as a two doses also, or they can take the different. But which day we have to give? So mifepristone is given on the day 1, and misoprostol is given on the day 3. Okay, after the 24 hours completing, then only we have to give the misoprostol. Okay, day 3. And if you see severe bleeding, then again we are going to proceed for the suction and evacuation. Next, how we are going to proceed the surgical? First one is the suction and evacuation. For the suction and evacuation, what is the procedure we are going to follow? We are going to use the Karman's cannula. Okay, Karman's cannula with the suction machine, and Karman's cannula will be corresponding to the number. Here you can see this is the Karman's cannula, and then there will be assigned with the number according to the uterus size. Okay, and what is the pressure we are going to use for the evacuation? Usually it is going to be the 600 mmHg pressure. Okay, usually this is done for the suction and evacuation. Next, another type of will be going to be the manual vacuum aspiration. So in the manual vacuum aspiration, we are going to use the syringe here. Okay, the syringe will be known as a Mva syringe, which will be contains the two pinch valves. Okay, it is going to contain the two pinch valves, and the capacity will be around 60 ml. That syringe capacity is 60 ml, and it is we are going to use the more than 660 mmHg pressure. The pressure is needed for this patient. This is how we are going to use the manual vacuum aspiration and the suction and evacuation, and what that's the dosage for the medical management. Okay, this is how we are going to follow the protocol. Next, moving on to the molar pregnancy. So in the molar pregnancy, you have the two types, guys. First one, this is here you can see where the fetus is present. This is known as a partial mole. Okay, next here you can see this is the complete mole. Okay, right. Now we see the difference between this. In the partial mole, the ovum is normal. Okay, ovum is normal, but it is fertilized with the two sperms. It is fertilized with the two sperms. Then it is going to form the triploid, right? So these triploid will be contains of the 69XXY. This is how the triploid will be formed in the partial mole. Next, in the complete mole, the ovum is going to be empty, and at the same time it is going to be mutated, or it is going to be formed with the one sperm. Okay, it is going to be one sperm, and it will form the only diploid, that is 46XX, because empty ovum is present here. This is the one thing. Then what are the chromosomes that is involved here? And here you can see the ovum is already involved, so that means maternal chromosome is present, and there is no maternal chromosome here. Maternal chromosome is absent. First thing. Next, paternal is present in the both. Here you can see the sperm is present in the partial and the complete mode. Next, we also have the investigation of the choice for this patient. What is the best investigation of the choice for this patient? That is ultrasound. Okay, on the ultrasound, if you see the appearance of the fetus along with the trophoblast trophoblast proliferation, then it is partial mode. And on the ultrasound, if you see only the snowstorm appearance and no fetus, this snowstorm appearance is due to trophoblastic proliferation only. That is seen in the complete mole. That is the first thing that you have to understand. And what is the gold standard for this? Biopsy is the best one. Okay, for the both patients, biopsy is the only procedure that we can do. Next, how we are going to treat this patient? First thing, for this patient, the management is always going to be suction and evacuation. Is suction and evacuation. Here also it is going to be suction and evacuation, right? But if you see this patient is having the, if they are more than 40 years, family is already completed, then we can go for the hysterectomy of this patient. The follow-up will be done in the molar pregnancies. Usually we will request the patient to stop the pregnancy, okay, for the at least 6 months. So in this 6 months, what you have to do is the beta HCG value should be monitored. So how? First, continuously after the immediately suction evacuation, every weekly we are going to take the sample. So if you see three values which will be showing the normal, then after that for monthly until 6 months. Okay, that's how we are going to proceed for the patients with the follow-up for the molar pregnancy. And for the stopping the pregnancy, we can recommend the patient to use the OCP as a contraceptive. Next, other things that you have to take note of the molar pregnancy is they are associated with the theca lutein cyst, theca lutein cyst, and these theca lutein cysts are regressive. Okay, after the molar pregnancy removal, they are easily going to be disappear from the patient. Next, moving on to the another type, goes gestational trophoblastic neoplasia. So what does mean by the gestational trophoblastic neoplasia? So apart from the molar pregnancy, we have other two types. One is invasive mole. So this is the benign lesion, and it can be turned to the malignant also. Next, we also have the choriocarcinoma. So these choriocarcinoma is associated with the trophoblastic tissue. So here you can see this is the inflammation, this is the neoplasia of the choriocarcinoma. And what is the tumor marker we use for this patient? Again, it is going to be the beta Hcg. So important points that you have to take note of the choriocarcinoma is it is most commonly associated with the full term pregnancy, and if it is associated with the full term pregnancy, then it is going to be the poor prognosis. Okay, and other than that, it can be also associated with the molar pregnancy. Okay, so what is difference between the most common with the full term, most common with the molar pregnancy? So if the examiner is asking you what is the following which is associated most commonly after molar pregnancy, then you have to choose the choriocarcinoma. And same question again with the full term, then also you have to choose the choriocarcinoma. But if they give the choriocarcinoma most associated with, then you have to choose the molar pregnancy. And whichever is associated with the molar pregnancy will be good prognosis. Okay, next things, the most commonly this patient will be having the bleeding manifestations. Okay, so persistent bleeding will be seen and persistent theca lutein cyst. So these findings is likely to be show that this patient is suffering from the significant neoplasia that is proliferating. And what happens, these patients will be also associated with the meds. So for that we have to know about the grading. So for that grading, as per the key, as per the staging, the stage 1 which will be including the uterus. Okay, so inflammation is within the uterus only. Next, stage 2, it is already spreaded to the pelvic structures. Okay, surrounding pelvic structures. And next, third stage is already meds, and most commonly it is going to involve the lungs, cannonball appearance you are going to see. And fourth one, other than the meds, it going to include the brain and also other organ, other systems. For example, liver and brain is going to be involved. So if it is in the first stage, we can go to give for this patient methotrexate. And if it is in the second stage, we have to give the pi regimen therapy. And this regimen therapy is known as a Bagshaw regimen. Okay, this is known as a Bagshaw regimen. The first thing that you have to remember. Next, moving on to here, the genital TB. Okay, so what does mean by the genital TB? It is not a primary. Okay, these tuberculosis is a secondary cause. Okay, and how was the spread? The spread is through hematogenous. So hematogenous spread which will be causing most commonly, this will be including the tubal, and tubal ampulla is going to be the significantly involved with the infection of the tuberculosis. So once they are involving this tubal, it is going to block this one. So most common symptom that is seen with these patients will be the corneal block. If there is a corneal block, the patient will be suffering from the infertility. Along with that, there will be associated with the dysmenorrhea in the early. Okay, dysmenorrhea will be seen, and over the time it can be transformed to the amenorrhea in these patients. Okay, this is the symptoms, and also other symptoms. You know, the fever will be seen, weight loss, and other symptoms like nausea, vomiting, night sweats. These symptoms will be also seen in this patient. An investigation of the choice for this patient will be biopsy, endometrial biopsy. We have to get the patient biopsy, then only we have to confirm. And when this biopsy should be taken, usually pre-menstrual period, there that time we have to get the biopsy, which will be helpful for us. Next, treatment, we have to go for the patient always TB therapy for the 6 months. This is the protocol. And how about the fertility treatment? Fertility for this patient, we are going to use the IVF as the best choice. Next, moving on to the pelvic inflammatory disease. So pelvic inflammatory disease, it's nothing but it is going to inflame uterus and also the pelvis and surrounding structures like tubes and ovaries. So overall, it is going to involve this entire structure. Okay, this is the common pattern for the patients, those who are suffering from the PID. Then what is the most common cause? The most common cause of these patients, the most common cause of the PID patients will be, it is associated with the chlamydia. Especially in the reproductive age, it is chlamydia. But if it is in the acute cases, it is gonorrhea. Then what about the patients, those who are using the IUCD? It is actinomyces. And those who are in the young age or virgin females, it is tuberculosis. And if it is old, more than 45 after the reproductive age, it is E. coli. These are the common organisms that is associated. What is the criteria to understand the PID? Usually the patient will be having the lower abdominal pain. Along with that, at least one symptoms should be present. So what is that one symptoms? It can be uterine tenderness. It can be uterine tenderness, or else it can be cervical motion tenderness, as we discussed in the ectopic pregnancy also, and even it can be adnexal tenderness. Okay, any of one of the following also we can consider this as a minimum criteria, okay, by the symptoms. Then if we see the other symptoms, it is a inflammation, fever will be seen, and associated with the bacteria which can show the discharge, mucopurulent or the purulent discharge will be seen, and inflammation will cause the ESR and the CRP levels elevation. Along with that, WBC count will also increase in this patient. So at least the lab test, the NAT or the positive, that should be also seen in this patient. And these criteria should be positive for the patients when we are doing. Next, what is the treatment protocol? For the chlamydia infections, you can proceed for the azithromycin. Okay, for the patients, those who are suffering from the gonorrhea, then you can proceed for the ceftriaxone. This is the protocol we are going to follow. And in this part, partner should be also treated. Okay, one thing that you have to remember. Next, coming to the ultrasound findings. Ultrasound findings of the patients with the genital TB. Usually, we are going to use the histo we are going to use the hysterosalpingography. Okay, we are going to use the hysterosalpingography. So in this hysterosalpingography, we are going to insert leech cannula. Okay, leech Wilkinson cannula. So with the help of the leech Wilkinson cannula, you are going to insert the contrast. Then we are going to look how we are going to see whether the dye is inserted, and then we are going to get these pictures. Okay, so here in this picture, this is known as a golf ball appearance. This is beaded appearance, and these both are known as a tubal block. So these are the pictures that is commonly seen with the patients. So this is what I was telling. This is known as a leech Wilkinson cannula. Okay, this is how we are going to insert. Next, coming to the ultrasound findings of these patients, those who are suffering from the PID. Okay, in the ultrasound findings of this PID, you are going to see the beaded appearance, and these beaded appearance is usually around the fallopian tube, and other sign will be cogwheel sign. Cogwheel sign will be seen. Next, complication on the laparoscopy. If you see on the laparoscopy, you are going to see the complication that is known as a Fitz-Hugh syndrome. Okay, Fitz-Hugh syndrome. This is due to when the adhesions is formed due to the chlamydia from the prehepatic tissue, from the prehepatic or liver to anterior abdominal wall, that will be causing this adhesions, which will look like a violin string appearance, that is seen in the patients of the PID. And this one also most commonly associated with the chlamydia in the patients, those who are reproductively active patients. Okay, and what is the common risk factor for these patients of the PID is due to multiple partners. Multiple partners will be the most common cause. Next, also one of the other thing that you have to remember, investigation of the choice for the lapro is the laparoscopy. Right, next we are going to discuss about the menstrual cycle. So here you can see the menstrual cycle is divided into the two parts. One is the follicular phase, another one is the luteal phase. Follicular phase is also known as a proliferative phase, right? And luteal phase is also known as a secretory phase. So let's see the differences between these two phases. So here, this is the first phase, which is also known as a proliferative and follicular phase. Next, second phase is known as a luteal phase or secretory phase. So this is dependence on the estrogen, and this is dependence on the progesterone. Right, the proliferation or the follicular maturations will be most commonly which ovarian cycle is overall will be started with the help of the follicular stimulating hormone. This is the first hormone that is going to initiate. Then we also have the in the first phase granulosa cells. So what does this granulosa cells will do? they are going to produce the estrogen too. Okay, and along with that, they also produce the inhibin B. So this is they are going to produce. After that, what happens? The estrogen to the LH will going to be the negative feedback mechanism. So LH is going to increase its surge with the help of estrogen. Okay, negative feedback mechanism. How much the LH surge will be? More than 200 picograms. Okay, this is how the effect will be shown. So after this LH surge, this will be causing the ovulation. Okay, so the ovulation will be causing here. How many hours is going to be the LH surge? Usually this is around 48 hours. Okay, this is around 48 hours. So before the ovulation, what happens? Both LH and FSH will be surge, but high picograms will be seen with the LH surge only. And LH surge not just maintained by the estrogen, it is also maintained by the estrogen and progesterone. This point also you have to take note. And what does this LH will do? It will be acting on the theca cells. Okay, so these theca cells will be producing the androgens. Okay, androgens will be produced. Next, moving on to the ovulation. Okay, this is where exactly at the mid of the cycle the ovulation is going to occur. The primary oocyte is going to convert it as a secondary oocyte, right? This is the first thing. Next, the ovulation main factors that you have to remember is usually the LH peak and the ovulation. The LH peak, here you can see this is the LH peak, and ovulation, these both are around 10 to 12 hours. Okay, these both are 10 to 12 hours. And if they ask LH surge, see LH peak and ovulation, this is 10 to 12 hours. Whereas LH surge, this is different, and this is around 32 to 36 hours. Okay, both are associated with the ovulation. Right, next moving on to the secondary phase, and in the secondary phase we have the secretory phase. Right, here most commonly they are important and they are associated with the progesterone. If they are going to be pregnant, then this progesterone is going to maintain along with the beta hcg, or else if the no pregnancy, then the cycle is going to be intact at exactly 14 days, and again there will be the shedding. So this is the secretory phase that we are going to see. And one thing that you have to take note about is corpus luteum. So what is this corpus luteum, guys? Usually corpus luteum is present as usually this is present in the all the females. So if this corpus luteum present in the non-pregnant woman, this is secreted by the LH. Okay, and if it is present in the pregnant, then it is seen as a HCG. Okay, this is how these patients, those who are with the her corpus luteum, will be important. And if there is no pregnancy, this will be going to dissolved for the next cycle. Next, moving on to the disorders related to the menstrual cycle. First, we are going to see the dysmenorrhea. So we have the primary type and secondary type. Primary type is going to be the physiological and secondary is pathological. So physiological is mostly due to prostaglandins and due to sudden loss or the sudden withdrawal of the progesterone. Next, pathological is most commonly associated with the endometriosis, or other than that, it can be fibroids also. This is the other cause. So first patient we can give and treat with the NSAIDs as a treatment of the choice. And for this patient, you have to treat the underlying cause. That's the first thing that you have to see. Next, another disease that is known as a middle smudge. So what is this middle smudge, guys? So it is mid-cycle pain. Okay, it is mid-cycle pain associated with the uterine artery tear or uterine artery. When we are moving that artery, when it is rupturing the follicle, it's going to cause this pain. So this is mid-cycle pain. Right, these are the some of the factors that you have to remember. Next, we are going to discuss about the primary amenorrhea and the most common cause, and then we are also going to discuss about the secondary amenorrhea. Okay, most common cause. So before that, we see what are the conditions associated with the amenorrhea. First, what is the primary amenorrhea? Usually, when I say primary amenorrhea, it is seen in two occasions. When the patient is more than 13 years old or patient is more than 15 years old. So, in the 13 years old patient, the breast staging is not developed, but here the breast is already developed. Okay. So, if the patient is more than 30 years, the breast is not developed, then still the absence of the menarche, then we can say this patient is associated with the primary amenorrhea. Then more than 15 years old, but the breast development is also seen, then still absent menarche, then we can also call this patient as a primary amenorrhea. And what are the causes that is associated with this patient? There will be multiple causes. First, most commonly will be genetic causes. First one is going to be the Turner syndrome. Right, Turner syndrome is a genetic condition. Usually what happens in the patients with the Turner syndrome, the patient is due to monosomy XO, that is the first genetic karyotype disturbances, and these patient will be having the dysfunction in the gonads, the ovaries are dysfunction. Next, same syndrome like Swyer syndrome. In the Swyer syndrome also it is due to gonadal dysgenesis, but its karyotype is 46XY. So this is also ovaries that is decreased. But in these patients, what happens? The FSH and the LH is going to be raised. So this is known as a hypergonadotrophic hypogonadism, right? Next, you also have the other condition, that is Kalman syndrome. Kalman syndrome is mostly due to hypothalamus disturbance. So these patient is usually what happens, this patient hypogonadotrophic. Okay, so in the FSH LH from the hypothalamus only there is a disturbance, and same with the gonads. So hypogonadism that is seen with the patients of the Kalman syndrome. Next, Mullerian agenesis. Mullerian agenesis. So these patients is usually uterus which is absent. So what happens? There will be the gonads will be normal, right? And also hypothalamus is normal. The only problem is the uterus is absent in this patient. So these are the some of the defects of the Turner syndrome. Next, other causes will be cryptomenorrhea. So the patients, those who are suffering from the hidden menses. So cryptomenorrhea, the most common cause will be imperforate hymen, right? Imperforate hymen. So when you examine this patient of the imperforate hymen, you are going to see the bulging and tensed hymen, right? This is you are going to see in this patient. So after that, when you do the surgery, what is the surgery that we are going to follow for this patient, guys? Cruciate incision, right? This way the incision will be done. So this is known as a cruciate incision. Surgery is done for this patient. So after that there is going to be the normal only. This is known as a cryptomenorrhea. Next we are going to see the secondary amenorrhea. Okay, in the secondary amenorrhea, this patient is most common. What is the most common cause, guys? Pregnancy. Okay, pregnancy is the most common cause for this patient. Or else the secondary causes like Sheehan syndrome due to the postpartum hemorrhage. This is also associated. Postpartum hemorrhage, usually the necrosis of the pituitary. This is going to be the cause of the patient. Next, some of the other symptoms are other prolactinoma. Prolactinoma condition can be, and PCOD syndrome, and even syndrome like Asherman syndrome. What is mean by the Asherman syndrome? Due to the patients, those who are having the DNC, this is going to cause the adhesions inside the uterus. So this can be also seen. These are the some of the causes for the secondary amenorrhea. Overall, that you have to understand, the most common cause for the patients for primary amenorrhea is going to be the Turner syndrome, or we can choose the gonadal dysgenesis. Okay, this is the one of the cause. Next, what is the most common cause for the secondary amenorrhea? It is going to be pregnancy. Next we are going to discuss about the menopause. So menopause is around 51 years average. So when we say the menopause, around more than or equal to 12 months. So if the female is not attaining their menses, then we can consider this as a menopause. So what is premature menopause? It is around less than 40 years they attain their menopause as early. Okay, this is one thing. But clinically, most of the times we are going to check the at least 12 months for the telling that the patient is under the menopause. Then what is the diagnosis we can do? FSH levels. So if the FSH levels is more than 40 international units, then also we can consider this patient as a suffering from the menopause. Okay, that is the thing. Next, symptoms. When it is comes to the symptoms, you are going to see the hot flashes. Suddenly the patient will be feeling the hot flashes. Why this hot flashes is most commonly seen? This is associated with a sudden decrease of the estrogen. Okay, first thing. Next, then also associated with the night sweats. Night sweats will be seen, and extreme heat that can be also seen in this patient. And always remember, these is commonly seen with this patients, those who are around the attaining the menopause like 50 or 40 age. In between this age they are going to see. And what is the treatment that I can give for the patients with the hot flashes? For this patient I can give fluoxetine. Okay, SSRI, this can be given because the imbalance is seen with the serotonin and norepinephrine also. Next, coming to the menopause, it can cause multiple factors. For example, it can affect the osteoporosis increase. Okay, osteoporosis will be increased in this patient. Again, this is also due to decreased estrogen, right? So when the patient will be seen, this osteoporosis can be associated with the vertebral fractures. Okay, these are known as a painless fractures. Okay, first thing. And then to increase this, what we have to do, we can start these patients on the bisphosphonate, or to prevent this condition, bisphosphonates can be given for this patient. But these are associated with the side effects such as gastritis. And also over the time when you give these drugs, this can also associated with the atypical fractures. Okay, atypical fractures will be seen with the bisphosphonates also seen, right? For that only we are going to give the other drugs, that is the treatment of other drugs will be teriparatide. Okay, parathyroid analogs that we can give for this patient. Next, atrophy will be seen. Okay, vaginal atrophy will be seen in this patient. That can be also due to decreased. We can use the lubricants for this patient. Next, coronary artery disease can be seen. So for that, you have to check the patients with the what are the important factors. Like you have to go for the lipid profile, and accordingly you can treat this patient. That is the first thing. Next, other thing you have to learn is the hormonal replacement therapy. So when we have to give the hormonal replacement therapy for this patient, usually hormonal replacement therapy is two types. One is the estrogen type and progesterone type. Okay, estrogen and progesterone. Next, other one will be combined only estrogen, right? So which are the benefits? Usually the patients, those who are taking the estrogen and progesterone, they have the advancement from the all the factors. Okay, for example, they are associated with the decrease of the hot flashes. They are going to decrease the cardiovascular risk, and they also going to decrease the osteoporosis. And along with that, there is a risk to decrease endometrial cancer, because if you give only estrogen, there is a risk of endometrial cancer, right? So this is a backlog for us. So for that we can prefer the patients with the, to decrease this one also we can go for the estrogen and progesterone, but they are the contraindications. Usually it should not be given in the patients those who are suffering from the breast cancer. Okay, and also though are have the risk of the thrombosis and MI patients, stroke patients, all the bleeding disorders or the active liver disease. So these patients, we are not going to give this condition, right? And migraine condition also, we are not going to give. This is the contraindications for the hormonal replacement therapy. Next, moving on to the endometrial conditions and the uterine conditions that we are going to discuss. Discuss about the following condition, guys. First, here you can see this is the polyp. Okay, so endometrial polyps, usually they are going to be the localized outgrowths within the endometrium. Okay, within the endometrium, they are going to be the outgrowths. So first, usually seen in the all age groups. Okay, this is commonly seen with the all age group, around 40 to 49 years of the patients. And what is the symptom they are associated? Most commonly post-menopausal bleeding. Post-menopausal bleeding will be seen with the patients of polyp. Next, on the examination or of the, when you see through the hysteroscopy, you are going to see the findings will be red fleshy. It is going to look like a red fleshy and smooth hanging in the uterine cavity. Okay, this is how you are going to see the polyps. First thing. Next, for the investigations, you have to go for the investigation of the choice for this patient is the Doppler. So Doppler is the best to see, visualize how the artery that is feeding this, especially this feeding the vessel of the polyp, whichever is causing the bleeding for this patient. Okay, that is the first thing that you have to take note. Next, moving on to the endometriosis. So the endometriosis, we all know that this is the condition due to most commonly retrograde bleeding, right? Retrograde menstruation, which is causing this condition. And most commonly, this is going to involve the ovaries as a extra uterine structure. So when they are at this place, when you are having the cycle, estrogen or the progesterone is working, so the plane will be seen on the extra tissues. So that is what endometriosis. So the ectopic tissue of the uterus is going to cause this condition. So this is the most commonly accepted theory, the implantation or the retrograde menstruation. This is known as a Samson's theory, right? Next, other whatever the features, usually it is going to include pouch of Dolgos, or it can be include the broad ligament for this patient. Next, coming to the symptoms. So, coming to the age of this patient, usually 20 to 35, reproductively active age. And nulliparous woman is commonly associated. Once they have the pregnancy, after that it is going to decrease, right? Most common symptoms all will be associated with the D's. Dysmenorrhea will be seen in this patient, and dysuria and dyschezia, and also dyspareunia. So these are the findings that will be seen in this patient. Next, when you are going to do the investigation of the choice will be laparoscopy. On the laparoscopy, you are going to visualize chocolate cyst. Chocolate cyst will be seen in the laparoscopy. But the gold standard for this patient is always biopsy is going to be the best thing, right? Next, MRI can be also done as a one of the investigation diagnostic test. Next, coming to the treatment plan. The treatment plan will be always first choice. NSAID should be given because always it is associated with the pain. So for this patient, you have to do the NSAIDs for the mild pain or the moderate. Then other conditions of the increasing in the condition, if the condition is increasing, progressing, like for example, if you see it is moderate to severe, then we can start this patient on the GnRH analogs. Okay, the GnRH analogs can be given for this patient. Next, coming to the fertility issues. So the fertility issues will be also associated with this condition. So when you see the fertility conditions, what can be done for this patient? The drug of the choice for this patient will be letrozole. Okay, letrozole can be given for this patient. That is the drug of the choice for the fertility issues. Next, moving on to the adenomyosis. So here the condition adenomyosis. What is the adenomyosis? The endometrium growth in the myometrium. So what we discuss in the patients of the endometriosis, it is ectopic, everywhere can be seen. But the adenomyosis is only seen in the myometrium with the help with the ectopic tissue of the endometrium. This is seen in the more than 40 years of the female, and it can be seen in the multiparous also. The difference between the endometriosis and the adenomyosis. Next, the most common symptoms, it can be associated with the menorrhagia. Okay, heavy bleeding will be seen in this patient, and chronic pelvic pain. chronic pelvic pain is also seen. On the examination, you are going to see the uterus will be globular. Okay, uterus will be globular and symmetrically enlarged. So symmetrically enlargement is seen in this patient. Next, the findings of the patients, usually you are going to see same, the tenderness will be associated. Okay, tenderness will be seen, and also adnexa pain will be seen due to the increase of the hormonal issues, that is also seen in this patients. Next, investigation of the choice for this patient is going to be MRI. Okay, MRI should be done, and only the treatment or the best treatment is total abdominal hysterectomy. That is the first thing that can be done for this patient. And if the patient is reproductively active or the family is incomplete, for this patient we can go for the contraceptive, and the contraceptive which we use commonly is the IUCD. Okay, intrauterine copper device should be given for this patient. Again, the investigation of the choice is MRI, but gold standard, then it is lab biopsy can be done for this patient. Okay, biopsy as a gold standard. Next, here moving on to the most common benign condition, that is fibroids. Okay, so let's see the importance of the fibroids. So fibroids, as we discussed, it is the most common, and this is the smooth muscle tumor. Here you can see this is the smooth muscle tumor, and they are three types. This is known as a submucosal. Okay, this is intramural, and this is known as a subserosal. Where these are the different types of the fibroids. Next, this is also seen in the patients of the 25 to 45 years of the reproductive age, and it is associated with the estrogen. Okay, those who are having the estrogen dependent tumor, that is fibroid tumor only. And the patients usually having the heavy menstrual bleeding. Along with that, the patient will be also having the pain. Okay, every cycle and all the cycles will be regular, and regular cycles will be associated with the heavy menstrual bleeding. That is the first thing. Next, grossly, if you see this patient, there will be you are going to see again globular. Okay, uterus, you can see it can be even look like a age of gestation, like uterus can be seen on the abdominal examination for this patient. Next one that you have to know about this one is they are associated with the calcifications. Okay, calcifications is seen. The most common will be hyaline, and in the pregnancy patient you are going to see the red degeneration. That is the first thing you have to remember. Next, this patient investigation of the choice is transvaginal ultrasound. Okay, transvaginal ultrasound can be done for this patient. Next, as the treatment, we can go for the myomectomy. Okay, we can go for the myomectomy if they are small fibroids. But if the fibroids is more, then we have to go for the total abdominal hysterectomy, and only if they are family complete. If the family is complete and they are large, then you have to go for the total abdominal hysterectomy. And for this also, we have to go for the Figo classification. So there is a classification, Figo classification. You have to take note, and each and every things of the pay, like what is the staging and where it is included, and what is the arteries are included, all the things that you have to consider, and risk factors. So these are the some of the endometrial disorders. Next, we are going to discuss about the PCOD. PCOD is commonly associated with the androgens. So when there are increased androgens in the body from ovaries, it is associated with the polycystic ovarian disorder. Usually what happens when there is an increased androgens, it is going to cause the hirsutism. Okay, so the hair growth that will be seen in this patient, and these androgens are folliculotoxic. So follicles can be damaged. Okay, no follicular maturation, so there is no ovulation and no corpus luteum. So associated with the infertilities, and also the patient will be having the amenorrhea or irregular cycles. Okay, irregular cycles, and also obesity, which will be seen over the time. They can also associated with the insulin resistance. Oh, overall, these all will be seen with the condition of the PCOD. Okay, next, what we can do, the lab findings we are going to see in this patient. Usually the testosterone will be increased, okay, due to an opposed increase of the androgens. Next, dehydrotestosterone, another derivative, can also be increased, and luteinizing hormone is increased. LDL will be increased in this patient, and estrogen will be also increased. Next, progesterone is decreased, and serum Hbg is also going to decrease, and no changes are seen in the FSH, and also prolactin, that is seen in the lab findings. What is the criteria that we are going to, when you are diagnosing? The criteria is known as a Rotterdam criteria. Rotterdam criteria for the ultrasound. Okay, and what is this Rotterdam criteria we is going to see? So first one is going to be the androgen levels. Okay, androgen levels are compulsory, is going to be increased. Next, second one is going to be the irregular periods. Irregular menses will be seen in this condition. Next, on the ultrasound, you are going to see the follicles. What are the follicles that you are going to see? More than or equal to 12. All are going to be 2 to 9 mm size. So these pattern will be seen. And ovary volume. So the ovary volume will be more than or 10 to 10 cc will be seen in the ultrasound. So this is known as a Rotterdam. And in this, at least 2 should be positive. Then we can consider this as a PCOD condition. Next, acanthosis nigricans also seen in this condition. Next, what is the treatment protocol? So the treatment protocol for the patients of those who are suffering from the PCOD is usually lifestyle. Okay, lifestyle modification should be done for this patient. Next, what is the drugs can be given? Metformin can be given for this patient for the insulin resistant. Next, OCP for the irregular cycles. Next, hirsutism, or the patients those who are suffering from the androgen dysfunction, again OCP can be given. Other drugs that we can give for those who are trying to conceive, spironolactone can be given. Okay, spironolactone can be given. For the infertility, what is the drug that we are going to use? Here also we are going to use the patients with the latrozole. Okay, latrozole can be given for this patient, and most of the times we think that it is a clomiphene citrate, but still we can go for the latrozole for the infertility treatment for this patient. Next, uterine abnormalities. Okay, so here you can see the most common is the uterine septate. Okay, this is the most common cause, and this is the arcuate where you are going to see this kind of the shape, and this is bicornuate unicorculus. Okay, only one vagina, but here two vagina and two uterus, and this is completely didelphys associated with the diethyl stilbestrol. Next, this is asymmetrical bicornuate, and this is only unicornuate uterus. So if you have to know about the important points from this, so the most common overall the uterine anomaly, that is septate. Okay, and most commonly associated with the abortions like second trimester loss, that is also associated with the septate uterus, right? These are the two things, 2 points that you have to take note. Next, heart shaped anomaly. So the heart shaped anomaly is bicornuate. Bicornuate is known for the heart shape. Next, the uterus didelphys, as I said, it is associated with the diethyl stilbestrol. Next, renal anomalies plus the uterine is associated with the which condition? Then you have to think about the unicornuate uterus. This is associated with the both condition. What is the best prognosis? The best prognosis will be associated with the arcuate. Okay, arcuate uterus. Here you can see this is the best prognosis that is associated, and whatever the normality that is only seen with the arcuate, and remaining all that can be sometimes associated with the condition. And what is the investigation of the choice for this patient? That is laparoscopy. This is the best choice to do. Okay, this is the gold standard and also investigation choice for the patients. Next, we are going to moving on to the uterine prolapse. In the uterine prolapse, you have to understand what are the types. So this is the classically the uterus is prolapsed. So when the, here you can see the bladder is prolapsed into the vaginal wall anteriorly, that is cystosine. On the posteriorly, the rectal wall is prolapsing, that is rectocele. Only the enterous condition that is coming from the vaginal pouch of Dalgos, that is enterocele. Okay, these are the types. Next, what are the important points that you have to take note about the prolapse? Prolapse is most commonly due to what, guys? Usually when there is a decreased support. Okay, when there is a decreased support. So usually what is the factors that is decreasing the support? For example, the ligaments. Okay, so the ligaments whichever is holding the uterus at point, that is decreasing. Okay, or else it can be due to muscles. The pelvic muscles is also not providing the support. So when these both are decreased, this can be causing the patients with the prolapse. And other than that, there is a mechanical support also. For example, we know that it can be antiversion or anti-flexion, right? So these anti-version at what degrees, guys? At 90 degrees, and anti-flexion at 120 degrees. Even if they are decreased, this mechanical support also, which will be causing the uterus prolapse. Next, what are the classifications we are going to use for the uterine prolapse? Usually POPQ classification, or we can also use the some of the WHO criteria also. So these are some of the classifications we are going to use for the uterine prolapse. Next, what are the things that you have to understand? The most common cause for the uterine prolapse is during the birth. Okay, so when they are going to be the prolonged labor, so which will be causing the most stress for the pelvic floor and also pelvic muscles and ligaments. So this prolonged labor is going to cause the one of the major risk factors. Next, multi-gravida. Okay, multiple gravida can be also cause this condition. Next, elderly female. Okay, elderly female, due to obviously the whatever the muscles is going to be, the condition is not like a young people, right? So that can also be cause for this patient. Next, what is the commonly they are going to associate with the decubitus ulcer? Okay, they are going to be associated with the decubitus ulcer. This is due to venous congestion. Okay, this is due to venous congestion, guys. And what can be the treatment we can do? Packing. Okay, packing should be done with the antiseptic. That is the first thing that you have to do. Next, what is the things that you have to remember when it is comes to the treatment? Okay, the treatment for this patient is usually going to be the So the treatment for this patient accordingly. If you see, this is from the anterior vaginal wall. So you are going to proceed for the anterior colporrhaphy. Okay, anterior colporrhaphy. Even though it is a urethrocoele or it can be cystocele. Next, Next, if it is a rectocele, what we are going to do, guys? Usually what we can done is the on the same the posterior wall we can go for the colpoperineo colpoperineoprophy. If it is a enterocele, then we are going to go for the mechalcaldoplasty because it is pouch of Dalgas, right? Mechalcaldoplasty, we can go for it. Next, vaginal prolapse. This is how we are going to proceed. Then what is the treatment for the uterine prolapse? For the patients of the uterine prolapse depends on the age. Okay, for example, if they are in the child age, okay, for example, they are childbearing age. For this patient, we are going to proceed for the sling surgery. Okay, this is known as a sling surgery, also called as a Shirodkar. Next, those who are between the reproductive age, like they are already who don't need any future planning, no family planning, but still in the reproductive age. For this, we are going to proceed for the Pother-Gill surgery. Okay, Pother-Gill surgery we are going to do. Those who are in the menopause, then we can go for the hysterectomy. Right, this is how we are going to proceed. Next, if they are more than 60 years, if they are more than 60 years with comorbs, then we can go for the Lefort colpoclesis. This is the protocol that we are going to follow. Next, who is pregnant with the prolapse, then we are going to proceed for the ring pessary. Okay, remember this. Next, moving on to the fistulas. First, you can see here the first one. What is this condition? Vesiculo-uterine fistula. So it is the connection between the bladder and uterus. Next, second one here you can see this is between the vesiculo-vaginal. So again it is between the bladder plus vagina. Next, third one, it is between the urethra and vagina. Urethra plus vagina. Next, fourth one, this is between the rectum and vagina. So these are fistula, the connection between the following structures. So what happens? The symptoms that you can understand when it is uretropistula. Okay, when it is uretropistula, this uretrovaginal, what happens? You are going to see the urine, continuous urine will be seen. Next, bladder and vagina. Here also you are going to see the urine. Continuous urine will be seen in this patient. Same as urethrovaginal also, you are going to see the urine which will be continuous micturition will be seen in this condition. Next, what is the most common cause for this patient? Again, this is also due to birth trauma. During the delivery, when there is a prolonged labor, this is also going to cause. That is the first thing that is seen with these conditions, right? These are the important factors and types that you have to remember. Next, so first we are going to discuss about the endometrial carcinoma. So endometrial carcinoma, important points that you have to remember. The most commonly associated carcinoma will be adenocarcinoma. Okay, this is the first line that you have to remember. And when it is commonly seen, guys, mostly around the more than 50 years of the age group or the post-menopausal women that you are going to see the condition of endometrial carcinoma. Next, the most common route of the spread, it is going to be the direct. The direct spread is commonly seen. The common complaint will be abnormal bleeding. Okay, the common so if you see the question, the most common cause for the post-menopausal bleeding, then you have to choose the polyp as per the India guidelines. Okay, polyp is most common than the patients with the endometrial cancer, because that is most commonly in India it is seen with the polyps, whereas developed countries you are going to see the endometrial cancers. Next, what is the risk factors? So the risk factors is usually Lynch syndrome. Okay, the Lynch syndrome or patients with the Cowden syndrome. Even hypertension can be seen, obesity, okay, smoking, and those who are having the more estrogen exposure from the childhood. So like early menarche or the late menopause, that can be also seen. Diabetes mellitus patient and endometrial hyperplasia. Okay, endometrial hyperplasia is seen, and also those who are suffering from the PCOS and those who are taking the hormone replacement therapy, and those who have never have the child in their life, and the drugs like tamoxifen. All these are going to be increase the risk factor for the endometrial carcinoma. Next, here you can see these are the stages. So the stage 1 is going to be confined to the uterus only. So the stage 1A endometrium, stage 1B is going to be the myometrium. Next, stage 2 is going to involve the cervix. Stage 3A, it is going to involve three difference. So the 3A will be involving the ovary, 3B will be involving the vagina, and 3C is going to involve the lymph nodes. And fourth stage, it is also going to be the whichever the metastasis, first regional to the bladder and then to the liver or the distant is going to be involved. Next, what is the protocol for the treatment? So the treatment protocol for this patient is always going to be the surgery. But how we are going to proceed? For the stage 1, we are going to go for the total abdominal hysterectomy with salpingo-oophorectomy. Okay, total abdominal hysterectomy with bilateral salpingo-oophorectomy. This is for the stage 1. Next, stage 2 and stage 3. For this patient, what we are going to do, we also going to do total abdominal hysterectomy with the bilateral salpingo-oophorectomy plus lymph node dissection should be done for this patient. Actually, not only 2 for and 3 stages, we also for the stages of the 1 also you have to do the lymph node dissection also that is involved. So that's why we are going to proceed for the debulking surgery in the fourth one. This is the first thing. This is the thing that you have to remember. Next, post-operative therapy. What is the chemotherapy or the radiotherapy we have to do? Yes, chemo should be given for this patient. Okay, along with that, radio also given for this patient. So chemo and radio both are given. Next, moving on to the cervical intraepithelial neoplasia. So this is a mostly pre-malignant condition. This is known as a pre-malignant condition. This is due to dysplasia. Next, here you can see these are the findings. This is first and second and third stage. So the first stage is going to involve only less than 1/3 of the cervical epithelial thickness. Next, stage 2 is usually it is going to be involved. Here you can see the stage 2 is going to involve 1/3 to 2/3 is going to be involved here. Next, stage 3 it is more than 2/3. Okay, this is cervical in situ. Before that, only the basement membrane is intact, but invasive it is already. Here you can see the proliferation, entire cervix is already involved in this condition. Then what is the malignancy risk? So the stage 2 and 3, this both are associated more than 5% risk. Okay, and more than 5%, and 3 is it can easily can increase almost 30% risk also seen sometimes. That is the first thing that you have to remember. Next, what about the age? Okay, age is around 21 to 30 years of the patients. Next, as per the ACOG guidelines, only the thing that we can do is the screening. Prevention should be done. Around the 21 to 65 years, you have to do the screening for this woman. Next, if you see the first thing, the as a diagnostic test, you are going to proceed with the biopsy if you see the changes. But on the screening, what we are going to proceed, the pap smear. Right, pap smear is a choice for the patients for the screening, but biopsy is a diagnostic. So management for this patient, CIN1, we can go for the observation because it is less than 1/3 only. The ablation can be done for this patient. Okay, CIN2 or 3 for this patient, we are going to use the LEAP. What is mean by the LEAP, guys? Loop electro-excisional procedure. With the help of the loop, we are going to proceed. For this is also OPD procedure only, where we are going to use the usually the excision will be done by the excisional procedures with the current only. So there will be less bleeding. The wire which loop is going to cut down and coagulate the immediately, so that their bleeding is also decreased. And some last of we can take for the biopsy for this sample. So this is for the CIN. Next, we also have the cervical cancer. Right, cervical cancer is usually, again, this can be the most commonly associated with the squamous cell carcinoma and human papilloma virus. In the human papilloma virus, especially the 16 and 18, these are going to be the factors. Next, early coitus, early first pregnancy, and multiple partners, multiparity, low socioeconomic status, smoking, HIV, OCP, all are going to be the risk factors for this patient. Next, these HPV is usually associated, what we discussed, mostly these are due to two factors. One is the E7 and other one is the E8. These factors is going to cause this risk. Okay, and when you see this condition, it can be due to CIN also. What we discussed above, it can be due to CIN also. Right? Next, important things that you have to remember, HPV vaccine is given for the all the age groups of the 21 to 60 years as a part of the prevention category. Okay, ideally this should be given even those who are less than 11 years, or those who are above the 11 year also, we can give this immediately. This can prevent in the futures. Okay, overall, this is the first important things that we have discussed, important PYTs from the INSMT and NEET PG, guys. So read this and also practice the MCQs, because you all know the OBG is going to be the very important for your paper to increase the scoring. Okay, so read well and practice the MCQs, and all the best. And until then, please do prepare well, guys, and practice the MCQs well. Okay, thank you and see you all tomorrow.